Welcome to Medicaid tobacco cessation coverage in Oregon, a case study. Before we begin, as a reminder, at the bottom of your screen, there are multiple application widgets you can use. All of the boxes are resizable and movable, so feel free to move them around to get the most out of your desktop space. For best viewing experience, we recommend using a wired internet connection and closing any programs or browser sessions running in background that could cause issues. For the best audio quality, please make sure your computer speakers or headset are turned on and the volume is up so you can hear the presenters, and make sure the media player on your screen is enabled. If you have any technical difficulties during the webcast, please let us know via the Q&A box. If you have any questions during the webcast, you can submit them through the Q&A box. This webcast is being recorded and will be available tomorrow and can be accessed using the same link you used to register. And now we'll begin the webcast, and I'll turn it over to our moderator, Pyle Martin.
Hi, first I want to thank you all for taking the time to attend this webinar to learn about what our colleagues in Oregon did to improve Medicaid tobacco coverage and how, with some lessons learned to inform those who might be considering similar goals. We have three speakers today. DeGuilio, National Director of Lung Health Policy for the American Lung Association, will give us the national context. Kat Livingston, Associate Medical Director of the Health Evidence Review Commission at the Oregon Health Authority, will share her experience from a Medicaid perspective. And Shira Pope, Health Systems Policy Specialist of the Oregon Health Authority, will share her experience from the public health perspective. Before we launch into the presentation, I wanted to give you the opportunity for a brief poll. The poll question is, what represents your role in tobacco control? And I ask you to choose the one that is most relevant for you. Is it state or local public health department, state medical office, university, nonprofit, healthcare provider, or none of the above? I'll just give you a few more seconds to complete the poll to give the presenters a sense of who's on the call today. And there we go. It looks like we have most people from the state or local public health department or a nonprofit. Thank you for completing the poll. Our first presenter today, I will introduce DeGuilio, is the National Director of Lung Health Policy and oversees the Lung Association's Tobacco Cessation Policy Project and directs 2 federal grants related to tobacco cessation coverage. She is the Lung Association's expert on tobacco cessation policy and healthcare issues, including Medicaid, Medicare expansion, and marketplace healthcare. Originally from Chicago, Anne received her BA in political science from George Washington University. Thank you, Anne.
Thanks so much. And I am just going to kind of set the stage so we can understand the context in which Oregon really was able to run with some really awesome work that they've done on quality measures regarding tobacco cessation coverage in their state Medicaid program. So I'm just going to start by providing some basic background information to kind of level set and provide some history in the national context of what has been happening kind of within the healthcare system and then specifically around tobacco cessation as well. So to start out, I'm sure everybody on this call knows, but in case there's somebody who doesn't, and just to remind everybody of the importance of why we're here and why we're talking about tobacco cessation, it's just really that tobacco use and smoking are still a major burden in the United States. It's the leading cause of preventable death and disease. We know almost 500,000 people die every year from a smoking-related illness. Additionally, specifically the Medicaid population and why we're at the Lung Association so focused on Medicaid and cessation coverage and cessation in general, as well as kind of nationally why Medicaid is so important, is the Medicaid smoking rate is over twice as high as the smoking rate for the individuals on private insurance. And in addition to all of the life lost and the cost of smoking from that perspective, we know that smoking takes a toll on the economy too, losing almost $300 billion a year. And when we talk about a comprehensive cessation benefit, again, just so we're all on the same page, the way the comprehensive cessation benefit is defined, and this is by the definitions from the Treating Tobacco Use and Dependence 2008 update, which is the most recent clinical guideline we have on tobacco cessation coverage. It includes 7 medications, which include the 5 nicotine replacement therapies, bupropion and varenicline. All of these treatments are considered first line in helping smokers quit. Additionally, there's 3 forms of counseling that are found to be effective in helping smokers quit: individual or face-to-face counseling, group counseling or a class setting, and then phone counseling, which includes quitline services. Unfortunately, we also see a number of barriers to accessing this care. And again, just to go over them very quickly, we're not going to spend a lot of time, but I think it's important to kind of level set. So any sort of cost sharing, so copay, coinsurance, or deductible, any prior authorizations, so needing to get additional permission from your insurance company or Medicaid office in addition to getting the prescription written by your provider, limiting either the duration you can be on the medication, the number of times you can quit per year or per lifetime, which can be really devastating, or the amount of money an insurance company will pay for or Medicaid department can pay for your cessation medication. So maybe we'll give you $500 to quit this year. Additionally, as I mentioned before, these are all considered first-line treatments. So stepped care therapy really does appear to be a barrier in this case, which means that the insurance company or Medicaid department will require a patient to try one type of medication and fail on that before they can get another one. And then the last one, and this one again, you might be scratching your head a little bit, but it's required counseling. So we know that the most effective way for a patient to quit is using a combination of both medication and counseling. However, for a lot of medications, including those on Medicaid, getting to counseling can be a hassle and can be a barrier in and of itself. Maybe you don't have enough minutes on your phone to do quitline services. Maybe you don't have child care or transportation, so you can either attend a group or an individual counseling. So we really just want to make sure that every door is open for somebody to quit and every door is the right door. So moving on, kind of a little bit about how we got here and how we got to where we are with Oregon and setting kind of some of the bigger picture. So first I'm going to kind of go through some of the technology. But part of it is also kind of looking at how our healthcare system has changed. And there are a number of different ways that it did. And I've got a couple of key dates up here. And I promise there won't be a quiz at the end. But, we've got the American Recovery and Reinvestment Act, or ARA, which was the 2009 law, and we'll get into that in a little bit, as well as the Affordable Care Act that was passed and signed in 2010. And then MACRA, the Medicare Access and CHIP Reauthorization Act from 2015. And all of these pieces of legislation brought key reforms on the national level that allowed states and localities to be able to run with a number of healthcare changes, including those in Oregon that we'll talk about in a little bit. So going back to 2009, got the nice little world in 2009. So what is the American Recovery and Reinvestment Act, or ARA? It was omnibus legislation that was really designed to kind of fund a lot of different programs as a recovery effort from the Great Recession. So long time ago, but one of the key provisions, and the key provision that we're going to be talking about today, is the Health Information Technology for Economic and Clinical Health. Never have to remember that again, it's high tech. That is how I will refer to it, that is how it's generally referred to, but that is the key provision that we're going to be talking about that really kind of set the stage for a lot of this. So specifically, kind of what is high tech? So high tech is a provision that incentivizes providers and eligible hospitals to meaningfully use certified electronic health records. And so what it did is it set standards on what type of electronic health records these providers and hospitals needed to use, and then included both incentive payments or penalties if these metrics weren't met, either through increased Medicare, mainly through increased Medicare payments. Or decreased Medicare payments if you did not meet these standards. These incentive payments were designed to pay for the technology. I believe it was about $40,000 an individual provider could have received in order to get to implement this technology, and then there are different amounts that hospitals could receive as well. And there were a couple of different types of programs, but the main one that providers had to go through was meaningful use. And the idea was that there are different stages of it, and in different stages, providers had to meet different requirements. So what happened? Well, as a result of this, the adoption of electronic health records increased dramatically. This chart I have is from the Office on the National Electronic Health Record Office. It's healthit.gov. There's got a number of different charts, but as you can see with some of these numbers, physician office EHR adoption was just around 20%. It's now, well, the most recent data that there is 2017, which has it at almost 86%. Hospital adoption rates have grown even more than that. So really, it changed kind of the entire way that hospital systems work. The other thing that this allowed to happen was for data to be collected. So key data was able to be collected, so you can set up reforms based on outcomes as opposed to based on the procedures that were done. So it could really turned kind of the payment system on its head in ways to incentivize performance as opposed to incentivizing just, performing procedures. There's also now an ability to pull population level data that didn't exist before. One thing that happened was the Medicare Access and Chip Reauthorization Act. That was that last thing. So eventually, meaningful use was discontinued, and MACRA, which is a new payment framework for Medicare. Again, Medicare was the main piece of the way that incentive payments were given to providers and hospitals. But it replaces a lot of the meaningful use metrics, but again, just kind of, moves the country and moves the needle towards more paying for value as opposed to paying for volume, which is a big thing in healthcare, and really kind of overall set the stage and was kind of a tonal shift in the country, which I think you'll hear eventually from our colleagues in Oregon. We're able to build upon a lot of that. And now kind of this next set of how we got here, kind of what are the cessation coverage requirements, and kind of how do these two things meld together, again, from the national perspective. And kind of one of the biggest things in cessation coverage requirements that happened was the passage of the Affordable Care Act. There were a number of different requirements for a number of different population levels, but specifically for Medicaid. So standard Medicaid, there's Section 2502, which removed tobacco cessation medications from being a service that could be excluded from state Medicaid programs. So states now are not allowed to exclude any of the cessation medications. However, they still are allowed to charge copays and put in place other barriers. There's a little bit of a different provision for pregnant women in Medicaid, and these went into effect in 2010, so almost right after the Affordable Care Act was passed and signed into law. The requirement is that all pregnant women on Medicaid are required to have a comprehensive cessation benefit with no cost sharing. So this includes both counseling and pharmacotherapy, whereas the standard Medicaid program does not address counseling, nor does it address any cost sharing. Another thing that the Affordable Care Act did was put in place the preventive services requirement, and I'll get to that in a second, but this governs a number of plans, including Medicaid expansion plans, as well as almost all private plans, including any plans sold in the exchange, small group plans, and individual plans. And the preventive services requirement requires any service given an A or a B grade by the United States Preventative Services Task Force to be covered without cost sharing, and that is in the Affordable Care Act, in law, in statute. Luckily for us, cessation receives an A grade, and that's both for all 3 forms of counseling and all 7 medications. And the big key here is that states are responsible for implementing this, and we'll hear a little bit more about this in Oregon. Because clinical guidelines are not necessarily insurance coverage, the Department of Health and Human Services, Treasury, and Labor issued a frequently asked question to kind of translate what the clinical service guideline is into what insurance language is. So there's that translation that goes there, which is the requirement is laid out there, but again reaffirms the 4 sessions of individual, group, and phone counseling, and then at least 90 days of cessation medication when approved, for at least 2 quit attempts a year without cost sharing or prior authorization. In September 2015, the USPSTF updated their cessation recommendation and again reaffirmed their A grade for both pharmacotherapy and counseling. And again, states are still responsible for implementing this. So there's still a lot there, but the requirement still does exist. And then kind of just bringing us to next steps, here's an image of our new case study about in Oregon that you're going to hear more about in a few minutes. I believe that should be in one of your widgets too. I would appreciate you waiting until after all the presentations are over to download it. And if you don't have it, please feel free to reach out to us because we're really happy to share it. And I will turn it back over to our moderator.
Thank you, Anne. In the next presentation, I welcome Kat Livingston to introduce us to present the tobacco metric in Oregon and how it was accomplished from the perspective of Medicaid. Dr. Kat Livingston is a family physician as well as preventive medicine and public health physician. She serves as the Associate Medical Director of the Health Evidence Review Commission and also is an Associate Professor at Oregon Health and Sciences University. She divides her time between clinical care, teaching medical students and residents, and translating evidence into healthcare policy for the Medicaid population in Oregon. Thank you, Kat.
Thanks for the introduction. So I work for the Health Evidence Review Commission, which is in charge of setting the benefit package for Medicaid in Oregon. And I'll be talking about Medicaid's role in all of this, as well as the metric. So this is a story of creating a cross-sector tobacco metric, and it took alignment between public health, the Oregon Health Plan, which is Medicaid in Oregon, as well as our metrics committee, which I'll give you more details about. So in order to understand what happened in Oregon, you need to know a little bit about our model, which is a coordinated care organization model. The ultimate goal of this is to provide better health, better care at lower costs, and involved a deal with the federal government where we got an infusion of federal funds in order to totally transform our delivery system. As part of making sure that we were doing a good job in terms of creating a sustainable rate of growth and making sure that we were still providing good quality care, we have developed a series of metrics, including financial incentive metrics for the CCOs, so for the Medicaid managed care plan, in order to make sure that we are helping to drive transformation, improve quality care, and decrease costs. So with these financial incentive metrics, tobacco was definitely of interest, and so we started exploring what kind of metric we could use for the CCOs. I'm going to give you just a little framework about the types of metrics that are used in healthcare settings because I think it's really important to understand why this metric is so transformational and exciting. So in healthcare, a lot of the metrics that are used are process metrics. So for tobacco, this would be things like, do you have a guideline in your clinic or health system that says all primary care physicians should screen for tobacco use and advise and refer? So that would be a process metric, having a guideline. Or another one might be every time that, that a PCP, a primary care physician, sees a patient, they check a little box in their electronic health record saying, yes, I asked this patient about smoking, and then that would count. The problem with these is that that doesn't actually mean that patients are getting the right service and the evidence-based interventions, nor that it's actually achieving the desired outcome. So as we move along this continuum, we could say, okay, well, let's push this a little further and let's make sure that patients are actually receiving those evidence-based interventions. So are there claims for the pharmacotherapies, for the nicotine replacement therapy and others? Are there claims for having behavioral counseling? And then if you go even further along the spectrum, you could say, well, are those actually working? So are patients actually quitting smoking? And if you want to go even further and talk about prevention, do we have less smokers? Have we decreased the prevalence of smoking? And that's really what Oregon has done, and that's what's very exciting. Most of the time, healthcare systems are not looking at all at population outcome metrics, and so this is why this is so transformative. So the group that decides the metrics for Oregon CCOs is the Metrics and Scoring Committee. So they go through hundreds of different metrics. We're definitely interested in looking at tobacco. There were a lot of process metrics that were available to them, but that's not where they wanted to go. They were interested in really trying to transform smoking rates. So in 2012, they considered a tobacco metric, and at the time it didn't pass. And there were two major concerns. The first was about effective measurement, and this really got back to that whole electronic health record that was previously discussed, where across Oregon there was not enough electronic health record implementation and functionality to really be able to gather the data elements that we needed for the metric. So over that period of time between 2012 and 2015, electronic health record use increased enough around Oregon, as well as the functionality of those EHR systems, to enable us to actually use data elements from the electronic health record. And the second major concern is that this metric required that CCOs, so Medicaid managed care plans, were accountable for decreasing prevalence of smoking. And so this is a little bit, this is very innovative. And a lot of the CCOs were saying, hey, why should we be responsible for prevalence? You know, these are patients who are choosing to quit or not. You know, we can offer evidence-based interventions, but why is it that the CCOs should actually be accountable for them quitting or never starting smoking in the first place? And so there was quite a bit of pushback about that initially, but over a series of conversations, a lot of input from state and local public health departments. Finally, in 2015, this was approved and went into effect in 2016, a tobacco metric. And so here are the components of that CCO incentive metric, which we call cigarette smoking prevalence. There's three major components. The first is meeting the cessation benefit requirement. So this is a pass-fail requirement. And it turns out that even though, theoretically, according to the ACA, all USPSTF A and B recommendations need to be covered, a lot of our CCOs weren't actually covering the cessation benefit as they should. So really making sure that they started covering pharmacotherapy and counseling. And what you'll see in these columns between 2016 and 2018 is that that percentage number goes down. So the weight of how much credit a CCO gets for actually offering the evidence-based package initially is 40% of their total weight, but it decreases over time. So the idea is that it was a heavier lift in the first year of the metric, and then they get less credit for doing that because they should have already included that benefit package. The second component of this is for reporting electronic health record-based prevalence data. So this was a technical challenge, and again, in the first year, there was a lot of weight given to this, and then over the subsequent years, as they've already done this and can do this, the weight of that went down. And finally, the third and most important component is for meeting the prevalence target. So this is actually decreasing smoking in the Medicaid population. And you can see that by year 3, this accounts for 50% of the weight. So by year 3, they have to have actually decreased prevalence in the Medicaid population. And here's what we've defined as the cessation benefit. It fairly well aligns with a comprehensive cessation benefit that was previously discussed. So we require at least 4 sessions of 10 minutes each of counseling, group counseling, telephonic counseling. I will do a point about the FDA-approved cessation medication. So there are 7. 5 of those are required for the Oregon Health Plan to be offered without any prior authorization or coinsurance. We never allow for coinsurance or copays in Oregon Medicaid. But 2 of those are actually very, very expensive. And so while technically that's part of the comprehensive cessation benefit package, Medicaid also has a duty to conserve public resources. And given that there are equally effective nicotine replacement alternatives that are not as expensive, we do allow for prior authorizations for 2 of the nicotine replacement therapies. The other 5 are not allowed to have prior authorization requirements. So here's what the actual guideline note looks like that requires the CCOs to cover pharmacotherapy and counseling. We do have a special call out for pregnant women, again restricting any limitations for pregnant women. Although a note, even though federal law requires the coverage of pharmacotherapy, there is very little evidence in pregnant women. So the other thing that the Health Evidence Review Commission did is create multi-sector intervention statements. And I think that this is a very novel approach that we're doing in Oregon, which is that sometimes the most effective intervention is not going to be with a patient and a doctor in a clinical exam room. And as speaking to a bunch of public health people, I'm sure that this is obvious, but not necessarily as obvious when talking to healthcare professionals. So the idea is that the Health Evidence Review Commission reviews the evidence in the same way that we review for medical procedures, but look at maybe community-based interventions or population-based interventions, and find ways that CCOs could potentially spend money in innovative ways that would actually help improve the health outcome we're looking for. So in this particular example, fantastically, the CDC's Community Preventive Services Task Force had already done this evidence review, which made it quite easy. But looking at all of the things that have evidence to support effectiveness for decreasing smoking, whether that's raising the unit price of tobacco products and smoke-free policies, to doing electronic health record reminders for providers and provider education. And so we adopted this at the end of our prioritized list, which is what determines coverage for Medicaid, and essentially gave the opportunity for CCOs to use their flexible funds to spend money in different ways. So they are not just limited to spending money at the patient-provider level in the clinic, but if they wanted to, they could also spend money on working on smoke-free workplaces or helping a clinic or health system develop these provider reminders or really kind of improve their electronic health record to specifically address smoking. So in terms of some helpful context and challenges to the tobacco incentive metric, one of the most helpful is that we had alignment between public health and Medicaid and metrics. All of us had a shared understanding of what the evidence was, what worked, and that this was an important goal. We all coexist under the umbrella of the Oregon Health Authority, OHA, and so this was really helpful because we have a mechanism by which to have regular conversations. Without these all being very highly evidence-based interventions, Medicaid would not have moved forward with this, and so the fact that we had such strong evidence guiding us was crucial. Finally, financial incentives are powerful drivers, and I think the fact that we used a financial incentive metric to drive this change is incredibly important. The phase-in period was important as well. So as I discussed, the first and second years, things like building up the electronic health record potential, kind of getting the cessation benefit package in gear, we allowed that to take time and didn't expect CCOs to be able to do everything all at once in the first year. And then health-related services. So we have a mechanism by which CCOs can pay for things outside of the clinical setting. Not every state Medicaid plan is going to do this, but all of them have access to this through 1115 waivers, for example. And so the fact that we already had a mechanism that allowed CCOs to spend money in innovative ways was certainly helpful. The challenges, novel metrics take a lot of work. It is so much easier to take an off-the-shelf metric that everybody else is doing. The problem is that a lot of those off-the-shelf national metrics do not create population health level change. And so Oregon had to create our own metric in order to get the change that we wanted. This idea of accountability is really important. I mentioned before, there was a lot of pushback as to why is it the CCO or the health plan's role to actually improve those health outcomes that may be outside of their normal jurisdiction. And ultimately, we decided that this was important, that CCOs are accountable to people's health, not just to health care. But I think that this will continue to be an issue, particularly if this is trying to be spread across the country. And finally, the electronic health record data issue was a challenge. It was certainly solvable. We engaged, we have a technical advisory work group with CCO representation, lots of data people who were able to figure out how to solve the electronic health record problem. So lessons learned from Medicaid, I think at the minimum is to cover evidence-based interventions. You know, there are a lot of Medicaid programs across the country who are still not covering these basic interventions of pharmacotherapy and counseling. While it differs from earlier in the presentation, I do think it's totally reasonable for us to only cover 5 out of 7 without prior authorization, recognizing that Medicaid still has a duty to consider costs. I think that there's an extraordinary opportunity to use metrics for innovative transformation, rather than just quality assurance, but really trying to push transformation, and our metric has done that. There is this need for flexible spending. There's an opportunity through 1115 waivers and using things like health-related services, like what we've done, in order to help CCOs be able to spend money innovatively. Private health plans wouldn't have any of these restrictions and could spend money in these ways if they wished. Finally, financial incentive metrics are powerful. This collaboration with public health was obviously critical. And the accountability piece, I think that this is where, you know, we've certainly talked about this with tobacco. We're talking about other metrics that have this similar accountability piece. And if we think about health plans actually being accountable for health, then we need to start talking about this more broadly. So here's a series of references. If anyone is interested in learning more about what we've done, including the cigarette smoking prevalence metric specifications, which is the very last one. And hopefully we can get more kids blowing bubbles instead of smoking.
Thank you, Kat, for that insightful presentation. Now that we understand the Oregon policy and the important groundwork laid by the Medicaid offices and the Health Evidence Review Commission, I wanted to turn our attention to Shira Pope, who will tell us the story of tobacco control in Oregon from the public health perspective, as well as the successes and challenges Oregon has seen in the 3 years since the smoking prevalence incentive metric has been implemented. Shira Pope has worked in public health and disease management for over a decade. She currently works as a health systems policy specialist in the Health Promotion and Chronic Disease Prevention section of the Oregon Health Authority's Public Health Division. Shira leads efforts for tobacco cessation, working with Medicaid and public payers on sustainability efforts and community clinical linkages for chronic disease prevention and management. Shira also has experience developing and supporting policy, systems, and environment change strategies that reduce the major drivers of chronic disease, including tobacco and alcohol use, poor nutrition, and physical inactivity. Shira received her bachelor's degree in psychology from the University of Oregon and her master's degree in exercise and sports sciences from Ithaca College. Thank you, Shira.
Thank you. So as Payal said, I'm going to be talking about really what public health's role was in this work with Medicaid on the smoking prevalence metric implementation. So the Oregon Health Authority and the state of Oregon have a long history of tackling tobacco, beginning over 20 years ago in 1996, when the Tobacco Prevention and Education Program in Oregon was established, which we refer to as TPEP, and with the state's 1996 tobacco tax increase. Oregon's statewide smoke-free indoor workplace law, the Indoor Clean Air Act, expanded to remove preemption and include bars, restaurants, and all workplaces as smoke-free in 2007. And then in 2012, Oregon established a policy prohibiting the use of tobacco on any state property. Additionally, there has been a long history of collaboration between public health and the healthcare partners across OHA for tobacco control. In 1997, the Oregon State Legislature included tobacco cessation as a Medicaid-covered service. This same year, the Health Services Commission added tobacco cessation to the list of Medicaid-covered services called the Prioritized List, and the Medicaid delivery partners at the time, which were referred to as the managed care plans before there were CCOs, implemented the cessation benefit package based on national clinical guidelines. So given the support through tobacco tax increases, Medicaid coverage, and public health, the Tobacco Prevention and Education Program and Medicaid began sharing staff to implement a series of performance improvement projects with the goal of incentivizing the Medicaid managed care plans to promote tobacco cessation benefits to pregnant women and clients with chronic disease. So when CCOs were established in 2012, public health and Medicaid staff were ready to work together to identify a common set of benefit design recommendations for tobacco cessation, as Kat mentioned, and then these early cross-agency initiatives really provided the foundation for a sustained and robust partnership across OHA to reduce tobacco use. So my role, as was mentioned earlier, is to support our tobacco cessation efforts within the Public Health Division, and specifically within the Tobacco Prevention and Education Program, which I mentioned began in 1996, and so that will be referred to as TPEP. And TPEP is a comprehensive program that supports tobacco prevention and helps people quit statewide. And this program has been in place for more than 20 years, ever since Oregon voters passed Measure 44, which raised the price of tobacco and dedicated funding to tobacco prevention and education. TPEP partners with local public health authorities, tribes, and regional health equity coalitions to prevent and reduce tobacco-related deaths in every Oregon community. This program has helped create smoke-free workplaces and outdoor spaces, transformed how health systems address tobacco use, and supported local solutions to tobacco prevention. So TPEP drives science-based interventions in each of the following areas of a comprehensive program to achieve its goals, as mentioned above. So state and community interventions We work on creating environments where a tobacco-free life is the easy option and youth are less likely to start using tobacco. For mass reach health communications, that's really developing media campaigns and education that support tobacco prevention initiatives and help people quit. Ensuring counseling and FDA-approved medication are available through quit lines and healthcare systems. Continuous monitoring of tobacco use trends and program effects to identify population needs and inform future areas of focus. And finally, ensuring there's leadership, accountability, and oversight for all program strategy and expenditures. And those really get at achieving those strategic goals of increasing the price, promoting tobacco-free environments, protecting youth from exposure, reducing access to tobacco products, and decreasing tobacco-related disparities. So Kat touched on the history of developing the incentive metric starting in 2012 and really what went into that. And so in 2016, a benchmark improvement in smoking prevalence was one of the 3 components of the bundled CCO cigarette smoking prevalence metric. So initially, simply reporting EHR-based smoking and tobacco prevalence data was included because the way tobacco was reported in EHRs varied significantly across the states. So some providers collected tobacco prevalence data while others collected data on cigarette smoking only. And that took time to consolidate into a single consistent measure. So Kat mentioned that the focus was really on cigarette smoking prevalence to keep with that consistency across all of the EHR systems in Oregon. So in addition, this 2016 metric required CCOs to cover a comprehensive tobacco cessation benefit. So when this metric was approved by the Metrics and Scoring Committee in 2015 for implementation, this requirement was more comprehensive than what was included on the prioritized list of what Medicaid-covered entities were required to offer. So in 2016, the Health Evidence Review Commission adopted this comprehensive tobacco cessation benefit that Kat provided an overview on, thus requiring CCOs to offer comprehensive tobacco cessation benefits as a part of their contract with the Oregon Health Authority. So recognizing that this tobacco benefit no longer needed to be incentivized because it was already contractually required by the Health Evidence Review Commission, the Metrics and Scoring Committee removed the cessation component of the cigarette smoking prevalence metric in 2019, and it became required as part of the contracts that CCOs had with the Oregon Health Authority to provide to their members. And then finally, although the prevalence metric remained, the target prevalence percentage varied for CCOs, as Kat explained earlier in the presentation, recognizing the differences in the populations that CCOs served. And this benchmark prevalence rate also changed over time to recognize previous successes from CCOs and encourage CCOs to continue to make progress year after year. So in order to effectively implement this metric and support challenges of implementation, the following systems were identified to leverage the work. So the Oregon Health Authority Transformation Center is the hub for innovation and quality improvement for Oregon's health system transformation efforts to achieve better health, better care, and lower costs for everybody in Oregon. And this the Transformation Center identifies strategically supports and shares innovation at the system, community, and practice levels. This group is responsible for technical assistance to CCOs to help them meet their incentive metrics. So every year, the Transformation Center administers a survey to CCOs, which provides the Oregon Health Authority with insights as to what specific benefits they are providing and if they are meeting the prevalence component of the cigarette smoking incentive metric. And so after careful analysis of the survey results, the Oregon Health Authority Transformation Center and TPEP identified together really where those technical assistance needs were in applying evidence-based strategies for CCOs. The Tobacco Prevention and Education Program works to connect the statewide network of local programs in all counties and tribes with their regional CCOs to replicate the comprehensive scope of tobacco prevention and cessation activities at the local level. So really what we're doing at the state level and work with where our CCOs at the state level we'd like to replicate at the local level. And so the cigarette smoking prevalence metric presented an opportunity for local public health and CCOs to form strategic partnerships to implement strategies that work. Specifically, the Sustainable Relationships for Community Health Grant Initiative was in place to accelerate these local cross-sectoral partnerships. And this competitive grant opportunity is administered by the Oregon Health Authority Public Health Division and requires public health entities and CCOs to work together, align shared goals, strengthen relationships and bring in additional partners such as clinics and community-based organizations to pilot, implement, and sustain activities toward a joint goal related to tobacco prevention and cessation. So that was really an opportunity to provide dedicated funding for those relationships across sectors and building those relationships to create kind of formal agreements to sustain this work together. And then lastly, as Kat mentioned, the health-related service funds are payments for services outside of the clinical setting that impact health outcomes and healthcare spending. So these funds give CCOs flexibility to use Medicaid dollars for non-clinical services, including multi-sector interventions, which include activities to support evidence-based community-wide tobacco control efforts such as mass communications, tobacco-free properties, and tobacco tax increases. So the goal of multi-sector interventions is to provide CCOs the information they need to reduce cigarette smoking prevalence in their memberships and larger communities, and to encourage them to play a role in implementing evidence-based community-level strategies alongside their local public health counterparts. And these funds were developed because the Oregon Health Authority believed the incentive metrics alone were insufficient to meet their goals of improving population health while reducing healthcare spending. These funds allowed CCOs to actually support the implementation of these interventions to encourage them to invest in population-level health strategies. So while it was clear that there should be a metric that directed CCOs to focus on cigarette smoking prevalence, there were still some challenges in the implementation of the metric, but also solutions identified. So the Metrics and Scoring Committee defined 18 metrics overall, but CCOs only needed to meet benchmark or improvement targets in 13 of those 18 metrics to qualify for incentive payments, which meant that CCOs didn't necessarily have to choose the cigarette smoking prevalence metric. Further, CCOs had great flexibility in defining how they planned to meet each metric, resulting in great variability in implementation. This flexibility afforded to CCOs in statute was really a particular challenge for the tobacco cessation component of the metric. Through the assessment and findings from the CCO surveys, it was found that some CCOs met the cessation component of the cigarette smoking metric through contracts with the state quit lines, while others met the incentive metric with in-house services, creating significant variability in the quality of the cessation services offered. So TPEP tackled the initial challenge of encouraging CCOs to choose the tobacco metric with targeted coordinated communication and collaborated across OHA to provide technical assistance at the Transformation Center. So through this technical assistance to CCOs, TPEP and OHA Transformation Center communicated the disproportionate impact of tobacco on their Medicaid population, the impact of tobacco on other chronic diseases, and thus how reducing tobacco use would also help the CCOs meet other incentive metrics. TPEP further used local and national data, including recommendations from the USPSTF and the Community Guide, to communicate information to CCOs on how to support local tobacco control efforts. And to ensure OHA tobacco messages to CCOs were streamlined, TPEP participated in monthly coordination calls with different chronic disease-focused sections in the Health Promotion and Chronic Disease Prevention section and coordinated with the Transformation Center for that. And then additional technical assistance planned by the Transformation Center and TPEP built upon two vehicles. The Sustainable Relationships for Community Health Competitive Grant Program, which I mentioned in my previous slide, and the Health-Related Services Funds. As I mentioned, the SEARCH grant is administered by the Public Health Division and requires public health entities and CCOs to work together to really align those shared goals and strengthen those relationships. And then those health-related services funds really allow CCOs to invest in those population-level strategies. And then finally, TPEP and the Transformation Center assisted CCOs in not only identifying community partners, but ways CCOs may use their flexible dollars, so those health-related services funds, to meet their cigarette smoking prevalence targets. So although implementation of this metric is a continual challenge, OHA addresses this challenge through communication and technical assistance, contributing to more CCOs meeting the metric in 2017 compared to 2016. With this history of collaboration, Oregon's waiver to allow for Medicaid funding of multi-sector interventions and tobacco dependence is a high priority for Medicaid coverage. It was natural for TPEP and the Health Evidence Review Commission staff to collaborate again when Oregon began thinking about a health system transformation initiative that addressed tobacco prevalence. With cross-sector and cross-agency collaboration and a shared understanding of the importance of tobacco control, Oregon took advantage of a national priority, moving towards improving quality of care and utilized quality measures to ensure tobacco control was included in their broader Medicaid transformation efforts. So collaboration across OHA was key to implementing this metric, and working with high-level leadership within both organizations to communicate the value of this cross-sector collaboration was necessary to elevate the impact of this work. So you can see how there has been a history of successful collaboration across public health and Medicaid, and really those key players that needed to be involved in order to successfully implement this metric. So in the first year, in 2016, 15 of the 16 CCOs met the cessation benefit requirement. All 16 CCOs met the requirement to report tobacco prevalence in their electronic health records, and 2 CCOs reached their cigarette smoking prevalence benchmark or prevalence target. So as a result, 15 of the 16 CCOs received their incentive payment in the first year. And then in the next year, in 2017, CCOs reported significant progress, with all 16 CCOs meeting the cessation benefit requirement and the EHR data reporting requirement, and 7 of the 16 CCOs met the benchmark or specified cigarette smoking prevalence target in 2017. So as a result, all CCOs received their incentive payment in 2017. And more importantly, prevalence of tobacco use has disproportionately decreased in the CCO Medicaid population versus the non-Medicaid population. So from 2011 to 2017, tobacco use among non-Medicaid members remained steady, so 14% in 2015 and 15% in 2017, while tobacco use among the CCO Medicaid members decreased 34% in 2015 to 27% in 2017. So Oregon's success in developing incentive metrics relied on 3 essential components, and these components can be applied to other states in order to overcome potential challenges when setting up policies. So for those states that might not be structured in a similar way, where Medicaid and public health sit together under the same agency, like Kat mentioned, we're all under the same umbrella of OHA, a shared recognition of the burden of tobacco and the return on investment of reducing tobacco use can still occur with coordinated communication. So states should work with high-level leadership within both public health and Medicaid to really communicate the value of this cross-sector collaboration to elevate the impact of this work. Systems mapping, a key to success for public health staff in Oregon, is necessary and applicable in any organizational structure. So understanding the relative agency, authoritative structures, and who should be present at key stakeholder meetings was essential to driving the change in Oregon and has application to other states. And then while the mechanism to success in other states may vary, an important component of Oregon's success was OHA's approach using structural elements that build upon the system the state has in place or is in the process of building. So in Oregon, this meant that public health needed to prioritize tobacco through the Health Evidence Review Commission, Metrics and Scoring Committee, and collaborate with the Transformation Center, given the structure created through legislation and the 1115 Medicaid waiver. And finally, a major challenge in Oregon was the concept of holding CCOs accountable for an outcome such as tobacco prevalence, which is highly impacted by variables outside of the community. So Oregon solved this by breaking down silos across the Oregon Health Authority and building community partnerships into their Medicaid system, from the governance of the CCOs to funding for actions such as support for a tobacco tax in collaboration with a broader community-led intervention, demonstrating the importance of investing in those multi-sector interventions such as mass media communication campaigns or tobacco-free properties for tobacco prevention. Other states can build upon meaningful use to make the case for and implement a tobacco prevalence and cessation incentive metric through communicating data, systems mapping, and their own collaboration within and across agencies and sectors. All right. Thank you.
Thank you, Shira. We are now entering the question and answer component of our webinar today. If you have not had a chance to ask your question, please do use the questions box it should be at the bottom of your screen. And in the meantime, I will start with some of the questions that I see. The first one is asking about smoking versus other types of tobacco. We talked a lot about smoking in the incentive metric in Oregon, and Victoria is asking, did you include smokeless tobacco users and e-cigarettes? And I'm going to start with Kat on that question.
So this is Kat Livingston again. So we included cigarette smoking, the use of other tobacco products such as chew, snuff, and cigars. The measure excluded the use of e-cigarettes, marijuana, and nicotine replacement products.
Thank you. Shira, did you have anything to add to that?
Nope. Kat got it.
The next question from Donna Ashbury is, how is churn addressed when using cigarette smoking prevalence?
So churn is a bit of a challenge. One of the things to know is that only the CCO Medicaid members are counted in the measure, so open card or fee-for-service are not. And so a lot of time when we have churn, people are going from CCOs to fee-for-service, and so open card was not included. The other thing is we have fairly geographic separation of our CCOs, so unless people are moving from different parts of the state to another, there isn't necessarily that much churn.
Thank you. Shira, did you have anything to add to that? Or Ann?
Nope.
Okay.
I would just add to that churn is generally speaking when somebody is referred to in the Medicaid context as when people make more money and then will go off Medicaid and then come back on money at Medicaid because their income will fluctuate, which is typical for people making around where the Medicaid cutoff income is.
Thank you for that clarification, Ann. The third question is from Rick Cajun, and he's asking, can you provide an example of the level of financial incentive that a CCO might receive and the overall cost of the incentive program? Were incentive payments funded by Medicaid, and what outcomes were achieved?
So incentive payments, so this is a Medicaid program where we have this money set aside for the financial incentive metrics. It's hard to specify exactly how much per metric, but it's in the millions of dollars range for the group of all of the metrics that are part of the incentive metric program. Shira, do you have anything to add to that?
Nope, you got that.
There was another.
Go ahead, continue.
So there was another follow-up question also from Rick Kagan that was talking about specifically about reimbursement rates for the different codes that are used for smoking cessation. I think this is a really interesting question of how should you try to encourage people to increase utilization of a good preventive service? So one option would be to say, hey, let's increase the reimbursement rate for counseling. So instead of making it $9.43 or whatever ours is, we could say, hey, let's make it $20 and really motivate people based on reimbursing at a much higher level. So I think that is a really interesting strategy. However, because we have this whole financial incentive program, increasing sort of the detailed reimbursement rates and the financial incentive program would be double dipping in a way. And so because we have this significant financial incentive program, we haven't been using those rates as much to try and encourage people to increase use. Instead, we're really using the financial incentive program to try and increase the outcome, which is working on prevalence.
Thank you. Any other thoughts on that point? Okay, we have one more question, and it is, where is a good place for my state to start on developing tobacco cessation quality measures like Oregon's?
Well, I think that's a great question. So we had to develop our own measure because the measures out there really don't get at what we're trying to do, which is to decrease prevalence. And so the off-the-shelf metrics that are available are inadequate, frankly. And so if you really wanted to do something exciting, you could say, hey, Oregon has developed this. Clearly, we've tested it now over 4 years. It's working in our state. You could certainly take ours, no copyright there, and use ours. I think trying to find another off-the-shelf metric that really pushes transformation in the way that we did just doesn't exist. So ours is probably the best one. Although the American Lung Association could try and further this and push this nationally if they wanted to.
I think we're going to let the experts develop the metrics, but we can definitely look into that. But I would definitely direct people to Oregon if they're interested in doing something similar to this, because I think, as was stated, you guys really got at the heart of the problem and created a metric to target that and to create the appropriate behaviors you wanted to.
Yeah, I think it's really important, too, though, that we really provided a comprehensive approach to this. So we made sure that Medicaid was covering all the evidence-based interventions. We made sure that there was lots of support through public health in our transformation center to provide the technical assistance. We had the technical work group that really tried to work out all the electronic health record issues. So really making sure that it's just not suddenly throwing this measure on plans without this kind of support, but really using all of your different levers of Medicaid and public health and the other levers that you have.
And one of the coolest things I think about, a couple of cool things I think about what you guys have done was first really kind of recognizing that you need coverage before you can, build upon that and ask people to actually, reduce rates. But then the other thing I think that's really awesome, which this webinar or webcast I think showcases, is really the partnership between the public health department and the Medicaid office. And I know the state was set up in a way that you could easily do that, but I think that was also something that probably, from a third-party perspective, seems to be a good working strategy.
Thank you, team. Seeing no other questions, I'm going to kick it back to Anne for closing.
Great, thank you so much. My contact information is on the screen, so please feel free to reach out if you have any questions. We really appreciate you listening to today's webcast. We're asking if you can please complete a short evaluation survey after the webcast is over. And if you've got colleagues that haven't seen this that you think might be able to, the webcast will be recorded as well as the case study is published on our website, as well as it should be in one of the widgets in the box. So please feel free to share that far and wide. And if you want to review the webcast, it's also going to be up there. So thank you so much for joining us, and we'll talk with you soon. Bye.
This concludes today's conference call. You may now disconnect.